Good morning, everyone. Welcome to the seminar. Thank you for access for everyone who shows up. I think we have some seats, so maybe we have people coming up later. So the few house items. First thing is I posted the group number, so just make sure you know the group. Anyone who doesn't know which group you are for the breakout session. Everyone knows the breakout session. Okay, now so it's posted. So you have 5 groups: A, B, C, D, E. So the name is arranged alphabetically. So its name starts with Z, so it starts with E, and it starts with A. Last name then starts with A. And this room will be number 1, and then we have room 3 is the middle table, and then we have another room on this side, and 2 and 5 are on the. If you go out instead of going to the kitchen, you make a right turn. So room 2 and 5. So we guide you. So every breakout session will have 20 minutes, and we have 5 minutes to change around from room to room, and it will be very informal group discussion. So instead of going through the lecture all day and putting you guys from beta to delta activity, so it's okay, have a breakout session to keep you alive and wake up. So you can free to ask questions, not during lecture, but after lecture. So okay, so our first speaker is Dr. Seal, Dr. Michael Seal. Dr. Michael Seal has been doing monitoring. He's a neurologist who did his medical school from Louisiana and Mississippi, and now he is practicing in Texas. He's doing for more than 16 years real-time monitoring. Pleasure to work with him every time. So when he's online, it's always a pleasure. So I'm going to introduce, ask Dr. Seeds to come and give his talk.
Thank you, Dr. Berry. Thank you. Turn off Siri first. Good morning. Thanks a lot. It's good to start off the conference this morning with my talk. With better communication, one of the things I have to say is that I'm a quiet speaker, so communication might be starting with me, making sure I talk loud enough for you to hear me. So if I get too quiet, just let me know about it. Let's see, there's a little remote here. That's it. Okay. So better communication. This is a very famous quote. I love it, and I've seen it used by other speakers. The single biggest problem in communication is the illusion that it has taken place. George Bernard Shaw. If it has not been documented, it's not done. No, even if it's not documented by we as the IP and technicians, it has to be documented somewhere, either in the surgery report of an anesthesiologist. It's not there by someone. It probably didn't happen, and certainly will create a problem. This is not a communication slide, but it's a slide that I like because it just tells us about what we do. And it was hard for me to take it out because I love it so much, and it's a reminder of all of our focus. Intraoperative neurophysiology monitoring has been utilized in an attempt to minimize neurological morbidity from operative manipulations. The goal of such monitoring is to identify changes in the brain, spinal cord, and peripheral nerve function prior to irreversible damage. Intraoperative monitoring also has been effective in localizing anatomical structures, including peripheral nerve cell, motor cortex, which help guide the surgeon during resection. For us who do craniotomies, that's a big part of our purpose. Now, this here, as a part of communication of relevant patient information, it's kind of simplistic, but yet it's very important, and those who have monitored with me know that I often go back to it, even though it seems like maybe it's kind of simplistic. The demographic, the patient age, the name, gender, the history with the diagnosis, symptoms, duration, prior brain and spine surgery. Is simple, but if you've been with me, I often go back and look at the symptoms of the patients when things are not right. I often go back and sometimes I would ask you, the age of the patient, because the age of the patient communicates to me what likely medical problems occur in that age range. So it's too important not to mention this. And there are some other important things that are mentioned to the IP interpreting physician right at the very early onset of the case, being those special considerations and precautions that we should know about, what the patient has: pacemaker, defibrillator, deep brain stimulator, maybe cochlear implant, pertinent medical history, like diabetes, thyroid disorders, whether they have a neuropathy, seizure history, things that we know is good for communication, really. And one of the things that I don't see typically added, whether the MRI films and so forth are present, because sometimes when the symptoms are just not making sense, particularly doing spine surgeries, I would often ask, are there MRI films present? Now, getting more to the very meat of this talk, I find that from my standpoint, there are 4 particular entities that I think about from a communication standpoint, that I'm always kind of tweaking my communication in preparation of talking with them. And the first one, as you see that I put here, is court and jury. Anesthesiologists, the surgeon, the technologists. Let's start with the first one, and this is some notes, some points that I keep in mind when preparing one day, hopefully, but it would never occur, but in the case that it does, I need to have focused my attention on this entity, that being a court situation. I said stay with the company protocol. It would hopefully satisfy established guidelines and some legal protection if that unfortunate situation develops where your notes are viewed by the court, by the jury. Notation detail: make sure notes can be read by the court and jury years later and with a clear and concise meaning. Make frequent and regular notes according to your company protocol. Surgery course, the technologist should make clear notes, chat notes for the jury that communicate the progression through different stages of the surgery. This is important because it helps the court in the future to follow the sequence of events and to understand the flow of the surgery and where you are at particular times when an alert might occur. So that's very important. Also avoid ambiguity, particularly in times of an alert. Don't use a lot of it, he, she, those particular pronouns, because you may not know who exactly you're talking about. Don't also use so many clutter words, or words that just doesn't make a lot of value to the communication, because it would dilute out important notes and you have to clean through those to see things, such as don't be so gracious all the time, like saying thank you 100 times, or saying that the surgeon is moving to one side of the table or the other, and it's nothing wrong with those, but don't overly do it. Also, in preparation, again, you can see that I'm talking about being ready to have your records presented to a court. Be ready to explain, make sure you state the surgeon's responses to different alerts that you bring to the surgeon. Document the surgeon's response. A lot of times when we see an alert and I ask the technologist to tell the surgeon about it, very commonly they'll tell them, but I don't know the surgeon's response. And I would ask them, well, what was the surgeon's response to that? If your records go before the court and you notify the surgeon of a particular thing, and they're going to wonder what was the surgeon's response. If you put that there, they understand a lot about subsequent decisions and action that may be made in response to the comment. So that's something you might want to make sure you're including in your chat notes. During the surgery, frequently review your chat notes to assure clarity of meaning and clear communication. One of the best things to do is leave your chat box open at times so that you can scroll back up and down and see if you're communicating accurately and clearly the things that are going on. I can also look at those and look at mine. Also, very helpful is at some point you might want to look back on one of your cases from like 6 months ago, and cases that maybe you've forgotten about, and read through it and see if you understand clearly the flow of the surgery. If you do not, then you can make adjustments so that you can improve in that direction. Also, finalize the reports quickly. They tend to be more accurate. You can remember things better, and they can be more concise. One of the other things I might want to mention before I go away from this, if you ever been sued about, I have, not from a monitoring case, but from another case that had to do with a brain infection, and you sit before the attorneys and you go through each line of your statement of your notes, line by line. Once that happens, it affects your chat and your communication and all records for the rest of your professional life. It's a bad situation to be involved with in a lawsuit, but there are some good habits that can come from that will serve you the rest of your professional life. Let's move to the anesthesiologist, and I have to admit, this is my most challenging area of communication is with the anesthesiologist. A suggestion is to communicate your ideal anesthetic regimen request to the anesthesiologist prior to the setup. If you want TIVA for more complicated surgeries, then this is your best time to ask for it. If they won't do it for whatever reason, then maybe you can ask for the next best, maybe half max, which might be drip. I find that it's better to ask then than during the surgery when your waves potentials are not as good. The second thing is the vital signs, and this is where I have the greatest challenge. I find that anesthesiologists don't mind adjusting the anesthetic agent, but when you begin to ask them to change vital signs, I think they believe we're becoming too intrusive. But most often, they will make some adjustments according to our request. You might also, before the case starts, ask them to keep the MAC at a certain level that you feel that will give the best response. We most often set it at about 80 millimeters of mercury. So make your request known in any discussion prior to surgery. Also form a relationship with the anesthesiologist. When you have a good rapport with them and you talk things over very frequently, they begin to know you, they begin to be more responsive, more cooperative. I find that as an interpreting physician, if the anesthesiologist is not happy, because I sometimes will ask them a lot, and I'm one that can easily get involved into a case, and I'm not sometimes so quiet, and I would ask them, request a lot of them, but if they're not happy, I'm not happy. It's sort of like if the anesthesiologist is happy, not happy, no one is happy. I find that even more than the surgeon. So this is my goal, to work and form a relationship most year. When it comes down to the surgeon, of course, I've talked about communication in preparation to the court. I've talked about just a moment ago with the surgeon, let's say with the anesthesiologist. With the surgeon, the biggest thing that you want to do to improve your communication is to talk with them, as with the anesthesiologist, prior to the surgery about the modalities that you would like to use. The surgeon might decide to deviate from your company's protocol. For example, occasionally surgeons decline motors during XLIF procedures. The surgeon may not want motors except for at baseline and closing. So normally no group would ever want baseline motors and just closing motors. So if that's a situation, you have to begin to communicate on another level. Certainly letting them know the deficits that might come across and your inability to explain them under those restrictions. So you need to advance your communication, maybe even use literature and so that they can understand we can do what you ask, but that's a risky request. I also like to keep conversation with surgeons to a minimum. The next line says surgeons should trust our data. This is the biggest area that I'm concerned with surgeons. You have to make sure that they trust your data. The biggest way I find to do that is not actually verbal communication or your body language. It's being very prepared to do what you're doing and having backup systems and doing extra modalities, some as backup, in order to be certain of, as certain as possible of the accuracy of alert information reported to the surgeon. That means sometimes putting extra SSEPs, extra motor set up, so that the greatest value in communication with the surgeon comes from providing them accurate data that they trust, that they can find a need for a service. And communication here means great preparation. The technologists communicate with each other, meaning the IP and the technologists should commonly do pre-surgery planning of their IOM approach, especially on more complex involved cases. If I have a very complicated case, and mostly for me those are craniotomy procedures and brain tumor resections, it's very often that I will call and talk with the technologists ahead of time, and Jane Blaylock can tell you that. I will call them ahead of time and say, hey, I said we got a craniotomy the next day. What is our approach? Also, come glasses, Dr. Gary is going to be on site, so you tend to get all of the people needed, all of the modalities discussed, so that you can proceed very efficiently. You're ready for any adjustments that might be necessary. When try to avoid interfering with the view of the active modalities when writing up your report. Sometimes during the cases, the technologists will pull up the forms for filling out the report and begin doing it right across the modalities. And I have to figure out how to get the screen out of the way of the wave patterns. Usually I would say something like, how the SCP is doing at this moment. And then I'll let the screen down, I can see the wave patterns, and I can comment. So I have to do some manipulation through the chat to get what I need to do to properly analyze the modalities. The accuracy of the report are likely to be greater the sooner the reports are completed. See how I'm doing with time. Alert responsibility. The primary responsibility of identifying the data changes is on the technologists. They have to immediately inform the surgeon and the IP. The IP is responsible for interpreting the data and making recommendations, as well as possibly talking to the surgeon if needed. No, I really didn't know this for a while. I just, to be honest with you, until recently. That's an important piece of information to know. It also makes sense because we often monitor more than one case at a time. When the technologist knows that they are the one that initially should find and notice any alert changes, then it helps me feel comfortable, even more comfortable doing several cases at a time, although it doesn't take away any of my need to observe the wave pattern. Keeping the peace. The technologists can help in this area, particularly when a very involved IP wishes and needs oppose those of the anesthesiologist. There are some cases when I'm getting in trouble by asking too many things of them, and the technologist can help me by telling me, well, the surgeon is not looking happy right now. Or maybe give them 5 minutes and see if the MEP might be coming up, because I think they might be given something to do it. So they can work to be mediators to help keep a comfortable working environment. This here goes to the reasons and purpose, behind the we're doing what we do. Keep in mind that the IONM potentials belong to the patient you spoke to in the prior to surgery. Read the history. Make sure you read the history, because it begins to give you an appreciation of the complaints of the patient and make you have compassion. Also, insurance companies in court can tell when you are only superficially and insufficiently attached. Try not to do too many cases for the IP, so that it interferes with your ability to appreciate the issues with each individual patient. In summary, let your notes represent and tell the story of the case for all who have legal rights to view them for many years to come. But anesthesiologists build a partnership with him, her, or let your request be known before the surgery starts. For the surgeon, build trust. Make sure they trust your data by perfecting your skills. For the technologists, work carefully with the IP so that you are a team working together with a common aim. In conclusion, the IP and the technologists, technician here, are a team. One should communicate such that years into the future, our reports can stand alone and clearly represent the events of each case. We should strive to form good relationships with the anesthesiologist and the surgeon. Our compassion should motivate us towards better communication with all who play a part in improving our patients. Thank you. We have time maybe for one or two questions.
Any questions?
I have an overall comment. Great talk.
Okay.
I think it's interesting, especially what you brought up towards the end about having feedback a little bit from both sides, because as interpreting physicians, we don't usually get feedback as far as how we're communicating. We don't get a lot of feedback or a lot of training as interpreting physicians on how to communicate, which is a whole science by itself. So I think it's a really great idea and concept to throw out there, is to have a little bit more of a two-way, because as you said, to get somebody to move the chat box can sometimes be a difficult way to frame the statement. Sometimes we'll just ask in the box, because it's okay if you have work boxes open and you're changing settings and all, but I think you can have some codes built into your communication with the people and say, hey, code words coming up like, how are the SEPs? Oh crap, I can't see them. But I think for us as people who monitor multiple cases at once and trying to keep everything straight and get a good workflow, I think it's a great point to bring up that, we need some opposing information from the other side that you have on the screen. How can we do this better? What do you guys think about the way I communicate? Can I be saying something a little different, a little better? So, good point.
Thank you.
So you guys have to improve your communication, so you need to ask questions. Communication. That's a zero communication, correct?
Well, I think if you have the ability to actually go and sit down with your oversight for a day and see what they do, somebody that also does both in the room and oversight, it's a different world behind the computer screen. And when you're watching 3 or 4 or 5 cases at a time, you're watching one case, so you're very centric to that one case. So if you can actually watch what they do, you'd realize when you have a chat box open and they can't see something, because they're not watching your screen 100% of the time, they're watching 5 or 6 other screens. So if you can get in and sit down with your neurologist or whoever does oversight with you, I think it's a great way to learn, you know, and I think the communication would be better that way as well.
So, as Dr. C's mentioned, it's always good to start communication before the surgery and have a communication with the anesthesiologist outside the room, not and the surgeon outside the room. Because inside, when you are in the room, so it's all war, like it's a war zones, and he's not thinking of it because he has so many things to think about. So try to communicate with the surgeon beforehand. If you have access to him in the OR or outside, text him if he's willing to give you the number. What type of surgery is it? Because sometimes it's posted as left side and it's right side craniotomy. Sometimes it's posted as a craniotomy, it's a spine case, or it's vice versa. So anything can change last minute and you don't have the grid or stimulator, and so it ends up with embarrassing situation. Plus, if you have a specific requirement, the patient is very have high BMI, has myelopathy or radiculopathy, and he has weakness or stroke or something. So you're aware of that. You can communicate with the neurologist, you can talk to the surgeon, you can tell the anesthesiologist, this patient is highly risky. So I need to have a high mean during surgery. So a mean of 60 maybe. If a patient is very hypertensive, we are going to talk about later. So I have a case where the patient I lost my MEP at baseline at a mean of 79. 79 is a very good mean, and I had discussion before exposure. So the patient has a mean of 120 pre-operatively. So that from 120 to 1, even if 79 was very high, but it was, so we increased the mean. Otherwise, patient, if there was no monitoring and there was no communication, we say, okay, I don't have a baseline and just go with that. So if you don't have a baseline, do something. So because sometimes people, they just go, they don't have baseline and they just keep, they say, okay, my job is done. I told the surgeon there was no baseline. And the other thing Dr. Singh mentioned was responsibility. So it's always, most of us, we keep blaming IPS, okay, he doesn't know anything and he's not helping me. It's always, but the most important thing is legally, when I hope you don't go to the court, but the primary responsibility of comes to the technologist to identify the change and then inform. The responsibility for the physician is to interpret the data. That's why they're interpreting. So you tell them. So it's just him saying, an anesthesiologist and or a surgeon. They are supervising multiple operating room and there's a CRNA and everything. And there's something they go and they call them and they say, okay. So that's why a physician can supervise 5 or 10 cases, whatever. Legally, there's no requirement as long as they're comfortable. But if there's a change, and as a technologist, if we do not identify and inform the physician, then the primary responsibility will come to you. So that's why the training and education is very important. So, because they say nobody told me, so they cannot go and look at every single waveform. So that's our responsibility as a technologist to look at every waveform. Thank you.
Thanks, Dr. C.